So my name is Jeanette Brown. I'm a pulmonary and critical care doctor with the University of Utah ALS Clinic. I specialize in neuromuscular respiratory diseases, including ALS. And today I'm going to be talking to you about breathing support in ALS, the devices, and tracheostomy. As I described in the previous talk, there are phases of lung involvement in neuromuscular respiratory diseases like ALS. This is based on Doug McKim's schematic out of the CanVent Ottawa program. And it describes basically the phases of lung involvement going from no respiratory complications all the way to very compromised, where in phase 5, devices are required to breathe. In phase 1, there are no complications. Phase 2, those patients are at risk for respiratory complications. For phase 3, you see signs of respiratory failure and disease progression. Phase 4 requires continuous non-invasive ventilation. And phase 5 is also continuous ventilation, but may be done with either a tracheostomy or the patient has decided their further goals of care don't include that. The other talk I gave talked about lung function, and when the forced vital capacity, or FVC, is below 50% predicted, or the NIF, or negative inspiratory force, is worse than minus 60, then we recommend patients start using non-invasive ventilation, also known as BiPAP therapy, to support their breathing at night. We start patients off with therapy just at night, but then they can progress to using these devices during the day as needed as well. And just like anything else, when you start something new, there can be an adjustment period that requires getting used to devices. And so there's a lot of different names that you'll hear. Non-invasive ventilation is the general class of devices, and BiPAP you may hear. BiPAP is actually a brand name. It's like saying Band-Aid or Kleenex. You may hear IVAPs, BiPAP, Trilogy, Astral, or Voxen. Those are all brands for the different devices, but those may be ones that we may recommend to help you breathe. So the question I get often is, why do we recommend these devices? What are they doing? And in ALS, we see that patients that use these devices have longer survival. And it depends on when the symptoms start, but survival advantage can range from anywhere from 13 to 19 months of life, depending on the study done. And this was compared to patients that didn't use these devices. And the new data that we have may indicate that patients actually may live even longer than that with these devices. And this slide here just shows an example of the different devices. Their size can be a little bit different. BiPAP, in general, devices often have to be plugged into the wall to be used, whereas some of the other ventilators like the Trilogy, Astral, and Voxen have internal batteries, and those can be more portable. And that might be something that's important to talk to your provider about, depending on what kind of activities you do. The other thing that's important to consider is the mask options. There are a lot of different types of masks, and one may fit a particular patient better than another. We all have different shaped faces, so that can be a consideration. Some patients only need a nasal mask or a nasal pillow, so that just covers their nose and helps them breathe that way. And other patients may benefit, especially at night, from having a mask that covers both their nose and mouth. And it's important that if you start with one particular mask and you are having difficulty with it, that you talk to your provider, because there are lots of different mask options out there for you to try. The other thing that can be helpful for getting used to these masks is to try just putting the mask on while you're doing something leisurely, like watching TV or reading a book, just to kind of get used to having it on your face without the airflow blowing. And it can be challenging sometimes if patients have claustrophobia. So again, we recommend things to do to desensitize to that feeling, such as wearing the mask while watching TV, wear it for a short time, and gradually increase the amount of time you're wearing it. Wear the mask alone without turning the device on. And again, trying different mask options. But it's important to talk to your provider and make sure they know if you're having challenges getting used to it. The other devices that we recommend are cough clearance devices. They are in a category, the medical term is mechanical insufflation and exsufflation device. The common terms for them are cough assistive device or vital cough device. And a normal cough is a strong inhale followed by a strong exhale. There are several of those models out there, but the important thing about them is to be able to simulate a cough for someone whose muscles are weak enough that won't allow them to cough. And then we usually recommend a suction machine because that can be helpful with clearing secretions as well. And you can also do what's called a manually assisted cough, which is can be demonstrated in clinic if you want to learn that as well. And this slide just goes over what a cough assist does. It has an inhale portion, an exhale portion, and a pause. And you repeat that cycle 4 to 6 times, and then you rest for 20 to 30 seconds, and then you repeat that sequence 4 to 5 times more. And the other question we get is, why do we recommend a cough clearance device or cough assist device? So these devices help to clear mucus from the airways and re-expand the lungs. They can improve oxygen saturations. And in diseases that are neuromuscular in origin, their rates of pneumonia have been reduced because it helps to remove that mucus that's in the lungs and re-expand the lungs. I've also been able to help use that if a patient chokes in the case of food, and you can use a mask or a mouthpiece depending on the person's mouth function capability. So unfortunately, ALS continues to progress, and then you can see respiratory failure with signs of disease progression. Typically, when I know patients are in this phase is when I'm seeing them use their devices more during the daytime. And it's important to work with your providers in clinic and assess your needs as your disease progresses. And one of the ways we can help patients is we have options for mouthpiece ventilation. And what that is basically a straw setup that works with your ventilator that allows you to sip on the straw and get a breath and help re-expand your lungs that way. And this is nice because it's not a mask in the sense that patients can talk, they can eat, but then, they have their breath support right next to them. And this can also be fitted to wheelchairs as well. So this can be used while a patient is in their wheelchair and away from home as well. So again, common questions we get with non-invasive ventilation or BiPAP is, can I get addicted to it? No, the studies would indicate that it actually helps to prolong survival. And so these are devices that we recommend people use if they feel like they need to use them. Another question is, will it make my muscles weaker? The answer is no. The disease progression is what's making the muscles weaker. And then the other question we'll sometimes see if patients have been looking on the internet at different devices is, can a diaphragm pacer help my breathing? And the answer is no. Those studies actually raised concern that they could potentially harm ALS patients, so they're not something we recommend. And phase 4 is, as the disease progresses, patients need continuous non-invasive ventilation or support from their ventilator. And this can be where you see that patients pretty much need the ventilator, majority of the day. They can take quick breaks off of it, but otherwise they'll feel short of breath and they need it more frequently. And weak breathing muscles can actually lead to respiratory failure, which can lead to serious complications. But the reality is that these devices can help to prolong survival, but weakness will continue to progress. And one of my roles at the University of Utah is that I'm an ICU doctor. And so I see people who are in respiratory failure pretty frequently. And I think it's really important to have a discussion about what your goals of care are. And these should be done early and often with your family members to get a clear picture of what you would or would not want as your respiratory failure progresses. And the question I often get is, what is a tracheostomy and what does it mean? And also the other options are hospice transitions and focus. And the main reason that people would elect for hospice is to focus on symptom control and quality of life. So what is a tracheostomy? So in this slide here, you can see that a tracheostomy is basically a hole in the throat that leads into the airway. They put a plastic tube in called a tracheostomy tube. And that allows patient to be directly hooked to the ventilator, and then the ventilator can do the work of breathing. One of the things that I always mention is tracheostomies are not often placed. We only place them in about 5% of our patient population with ALS. And they definitely can require a lot of care to take care of the tube itself and the neck stoma site. But also at this point, the neuromuscular disease has progressed. And so arm and leg weakness may have progressed to the point where patients are wheelchair bound and bed bound as well. Again, not very many people elect for a tracheostomy. It unfortunately does not prevent the progression of muscle weakness. It does not prevent infection. There are times where speech and swallow function can be affected as well. So that's something to consider. There's no guarantee necessarily as well with secretion management, and it can be better or can be worse afterwards depending on the areas of weakness, especially with patients who have bulbar weakness. And it's important to talk to your providers and your family about whether you would want a tracheostomy at the end of your life or not. And when I'm having these conversations in clinic, I think there are two questions that I really pose to patients and their families is, what are your life goals? Because this can help shape your decision and care. And then what symptoms do you want to control? What's most bothersome, or what do you want to focus on? And then also, what are the things that you don't want? You know, if you don't want a tracheostomy, it's important for your family members to know ahead of time. So if in case of illness, that they can honor your wishes. Also, many patients will have thought about whether they want something called a DNR or a DNI, which stands for Do Not Resuscitate Order or a Do Not Intubate Order. These, again, are something really important to talk with your family about in emergency situations. One big question is, what are your concerns about death and progression of your disease? In palliative care, which is a service that can help focus on symptoms and goals of care, is important, as well as hospice organizations, which can help facilitate those wishes as well. I know these can be difficult conversations, but in my experience, I have found that people who talk about these things early actually have a better clinical course overall, that patients' wishes are honored and families are able to do those things for patients. So in conclusion, we talked about the phases of respiratory involvement and the devices that we use and recommend to support patients in each phase. Again, phase 1, there is none to minimal respiratory complications. In phase 2, we're doing lung function tests in clinic to look for respiratory compromise. In phase 3, we have respiratory failure with signs of disease progression, and that's where we're having patients use BiPAP or ventilators to help support their breathing, in addition to the cough clearance or cough secretion devices to help them clear out secretions and to re-recruit their lungs. And then progression through phases 4 and 5 is when the disease has continued to progress and devices are used continuously. And at that point, it's important to have very clear goals of care going forward. So one of the questions we get is, what is a BiPAP machine and how does it work? These devices push in air and they have 2 pressures. That's why it's called BiPAP or bi-level. In the top pressure, the higher pressure allows the lungs to expand. And then the low pressure allows that area to be released without the lungs completely collapsing at the end. One of the questions we get is also, what's the difference between a CPAP and a BiPAP? So CPAP is used for a condition called obstructive sleep apnea, and it's only one pressure, in contrast to a BiPAP, which does more of the work of breathing and has two pressures, a high and a low pressure.